Hi, Dr. Chen, you have your hand raised. Do you have a question? Oh, okay, you're the people from Brain. Oh, how you doing? Can you speak? I'm trying to let you in the channel. Trying to get you in. Can you speak? Oh, okay. Why do you have your hand raised, Dr. Chen? Do you need something? Hello, everyone. Dr. Abu Bakr. Oh, Dr. Abu Bakr. You're from Cameroon, not Cameroon. Yeah, Cameroon, right? Oh, Dr. Ayman. Okay. Oh, okay, from Libya. You don't have a camera, Dr. Ayman? Yeah, you have a camera. You just need to turn it on if you want to. And Mr. There you are. How are you doing? Let me get on here.
Hi.
How are you doing?
Hi, doctor. How are you?
This is when I recruit people. Libya Grand Rounds.
Yes.
So
I really
someday,
appreciated it. And I'm pleasure to join you and other colleagues.
oh, okay.
Big chance for me.
Oh, good. Good. Well, we'll be glad to start Olivia Grand Rounds.
I hope that, but I'm not still not neurosurgeon. I'm just
Oh,
a
okay.
resident.
Oh, okay. That's okay. You can help organize it.
We hope that.
I'm not a resident. I'm just a doctor. So you don't have to be a neurosurgeon, although a neurosurgeon resident can run it. I mean, can organize it, help organize it. Do you know what I mean? Oh, Ibrahima, good. Oh, good, good, good.
We have a few doctors, neurosurgeon here in Libya.
Yeah, I
That's
know.
why it will be a big difficulty.
Well, the internet is made for people spread out.
Yeah, yeah.
You don't need to be in the same room, just the same computer. Ibrahima.
Hey, Mr. John, how are you?
Ibrahima, I got a big surprise for you.
Oh, really?
Yeah, you're going to be the host today.
Oh, my goodness.
Well, do you want to?
I'll be happy for that.
Okay, good. What I'll
yes,
do
of
is,
course, I can.
okay, well, I'll introduce, okay, I'll do an introduction, then I'll turn it over to you, and then you introduce yourself, and then Dr. Ben, then Dr. Ben, okay? And he'll introduce
all right.
He'll introduce Iype. Because Iype,
all right,
Dr.
all right.
Say hello to a fellow
okay
African.
like
okay, good. But do you have a camera? Do you have a camera?
Yes. I'll be happy for that.
Yeah. We need.
I want to. I'm trying to connect now on my computer
Oh,
because I'm
okay.
using my phone
Okay.
now. Yeah,
Yeah.
just
Okay.
let me
When
get
you okay,
in directly
whenever.
by my
There's
phone.
no. We got time. Don't worry.
All right.
Ayman, Dr. Ibrahima is from Guinea, Africa.
Uh-huh.
Yeah, he's going to host.
Okay. Excuse me, sometimes I want to unmute myself because I'm doctor of duty. Sometimes they call me. That's why sometimes
Yeah,
I
yeah.
will mute.
That's okay.
I mute myself.
Yeah. You should stay muted the whole webcast unless
Okay.
you're speaking.
Yes, yeah.
Oh, good. Juan Lee's here. Juan Lee.
Hi, yeah, this is Johnny. Yeah, I'm here. Hi.
Yeah. I tried to get you to send you the link, but I couldn't
Actually,
find you. I couldn't.
that's okay. That's okay. I had the link.
Oh, okay.
I think Bing Xu told me he's now in Indonesia for some meeting, so he might not be
Oh,
here.
Doc-
But yeah, but no problem. I can be here for the whole night, so that's okay.
Okay. Oh, okay.
I
So
can.
Ben. Oh, so
Yeah.
Ben might not be here.
Yeah, at least maybe not at 8 a.m. He said he's
Okay.
in Indonesia now. That
Oh yeah,
should be
Indonesia. He mentioned that.
yeah, that should be around 10 p.m.
Okay.
I guess
Okay.
he,
I'd like you to meet. Oh, you know Ibrahima probably. He'll introduce you. Okay.
sure. Okay. So
Ibrahima.
now we have two speakers. One is Iype, right? Iype from Nepal. Yeah, I know him quite well.
Hi.
And then
You know Iype, right?
another yeah, another lady neurosurgeon from our hospital. Actually, now she's in UK. I guess I remember should be in Oxford as visiting scholarship.
Okay.
Visiting scholar. Yeah. So yeah.
Okay.
Okay.
Do you know Ibrahim? Ibrahima, are you there? Okay, I'll have him introduce you, and then you
okay.
introduce Iype. Okay, you know Iype, right? Iype.
Yeah, of course I know.
Yeah. Okay. Just
Hey, Doctor, I'm here. Trying
Okay.
to switch off on my computer.
Are you okay, Ibrahima?
Yes, I'm okay. I'm trying to
Ibrahima.
switch off on my
There you are.
computer.
Okay.
Yeah,
Your
I'm here.
beautiful face is there. Now, what you know Juan Lee, right? You know Juan Lee?
Yes.
Hi.
Just give me a minute. I can try to reach on my computer. All right.
Okay.
Sure. We
All
have
right.
10 minutes. Yeah.
A minute.
Right.
Yeah,
I just
Start
want to
at
try.
8.
Okay. I can fix that before that.
So how you been, Juan Lee?
Yeah, it's okay. Yeah.
Everything's okay?
Yeah. Okay. Yeah. Yeah, now everything okay, goes smoothly. Yeah, we just do our daily working, like see the patients, do surgery, have some meeting. Yeah.
Do you do, do you use the exoscope at all?
What? Extrascope? Oh, no.
Do you use the exoscope?
No,
No,
not yet.
okay.
Yeah.
Okay,
Yeah, I know, doctor. Yeah, if we'll talk about exoscope, yeah,
Yeah.
for me, for myself, I only saw that during some exhibition, but not used by my own.
not in
But
the
yeah,
OR, not in the OR.
yeah, I think in our hospital we don't have it yet
Oh, okay.
in the OR. But yeah, I know there's some other hospital, the doctor start to use it.
Yeah, well, Iype seems to like it, and that's all he uses now. And his residents like it, you know, they ask him, can we use it? Instead of the microscope.
Okay.
So what you'll decide for yourself. That's right. I remember Dr. Ben mentioned he's in Indonesia.
Oh yes.
And he's coming to Brazil, I understand.
Oh really?
Yeah, a neurosurgeon from Brazil said he's coming there. He didn't say when.
Yeah, being he like travel all around the world.
Well, yeah, now that you can leave, it's like
Yes.
like your mother finally let you out of the house. So Ibrahima, how's it going? Oh, you're on your computer now.
Yes. Yes, now I'm in the computer.
See if you can put a background on.
Yeah,
I think we can make your background more prettier, like mine. Kind of
Okay,
like-
all right. Let me do mine too.
Yeah. So that people will think you're in an exotic place and not in a room.
Okay.
You know how to do it, right?
Yes, I can do it. I can do it.
Okay,
Let me do that.
okay.
Much better, right?
No, you haven't done it yet. Oh, that's just blurring it. You want to try to put an image on.
Okay.
What you do is, you know how to do it? You go.
Yeah,
the
yeah, I
sheet-
know, I know, I know.
Yeah, and then you just search on your computer for an image. Oh, Harshad is here, good.
All right.
There's Takashi. How you doing, Takashi? You're muted.
I'm fine. Now I'm in the night shift and I'm have time to join. Thank you.
Oh, good, good. Yeah, we have a good group here. We have Ashad, Wan Lee, and Iype will be coming shortly. We hope to have Dr. Ben come later. He's in Indonesia.
Indonesia. Okay.
Yeah, I guess a conference there.
Yeah. I'm thinking of going to ASNO, so brain tumor, American Society of Neuro-Oncology will be held in Indonesia. So I would like to join this October.
Oh, really? There's a big
Yeah.
neuro-oncology?
Yes.
Oh, okay.
This is my first visit to Indonesia. I will go to Hong Kong next February.
Oh, okay.
Hmm.
So you're starting to travel.
Wonderful. Okay. Actually, I think the second speaker, Dr. Yang, is already here. So, do you think we should wait for Iype? Or we can...
Yeah, I'm talking to Iype now. I want to see if he,
Okay.
okay. Yeah, I'm talking to him with what's up. Hello, Dr. Yang. You're muted. Okay, I'm waiting to hear from Iype. Okay. Okay, I guess Iype is not answering. Okay, Wan Lee, we'll start with Dr. Yang, okay? I'm gonna let me introduce Ibrahima. He's gonna introduce you. Okay?
Okay. Okay.
Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett televising from beautiful Miami Beach in Florida. We have another China Neurosurgical Journal webinar, bi-monthly. And we have a couple of speakers today, and we're going to start things off with a resident from Guinea that's doing his neurosurgery residency in China. Welcome, Ibrahima.
Oh, thank you, John. Thank you for inviting me here, and it's a great honor to be in part of this panel. And thank you, and nice to meet all of you. My name is Ibrahim. I'm actually in Huashan Hospital. I'm a fellowship actually in staying with Professor Cherian. Today, I'm gonna be one of the panelists in this webinar. So today we're gonna have two speakers. So John, I'm gonna be the moderator right now, right? You'd like to say?
You just introduced Wan Lee.
Okay. Okay.
He's going to introduce Dr. Yang.
You mean I can introduce Yuan Li Chao, right?
Right.
Okay. All right. Give me a second, so please.
As you can see, this is very professional.
Yes. I can see that. Okay. All right. So I'm going to introduce Professor Chuan Li is from Tiantan Hospital. Is that is?
Yes.
Because I don't have all the information. Yin Yang Li is a MD from Beijing, from Tiantan Hospital. He's going to have the presentation about neuromodulation, therapy of disorder of consciousness. And we're going to give you the speech, Dr. Yang Li. Welcome.
Thank you.
Okay, thank you, Ibrahima. Yeah, so, thank you, John. Now, the first speaker will be Professor Yang. She's a lady, a female neurosurgeon from our Beijing Tiantan Hospital. And today, actually now she's in Oxford or Cambridge. Yeah, but
Yes.
anyway, yeah, that's in UK as a visiting scholar. So today she will talk about deep brain stimulation for the treatment of some consciousness disease.
Yeah,
Thank you, Dr. Yang.
yeah, we want to see your face, Dr. Yang. That's why I took it off the screen share. Hey, let me take
Yes.
you off the screen, okay?
Can
Because
you
we
see
want to
me?
see your face.
Yes. Yeah.
Hey, we want to see your face. Could you please introduce yourself?
Hello, everyone.
Yeah. could
Can you
please
see me?
introduce yourself?
Can you hear me?
Yes.
Can you see the presentation here? Can you see the presentation?
Yes. Perfect.
Oh, okay.
We can
Perfect.
see.
Thank you very much. Thank you very much. Hello, everyone. My name is Yang Yi, and I worked at Beijing Tiantan Hospital. And I really exciting to be here and chat with all of you. Our teams have a topic to share today, and I will presenting it to you. The topic is deep brain stimulation for the disorder of consciousness and the future, the history and the future. And as all we know, the consciousness has always been such a fascinating topic. They both captivating both the general public and the scientists. It's right up there with mysteries of the universe, orange and the life evolution in the world of nature science. So what is the consciousness? It's all about being aware and attention to the world around us and ourselves. And the scientists are dividing deep into the biological basis of consciousness. They look at the brain activation, network, and connectivities to understand how our objective experience and the mental state to be. And it's like they are on a quest to unravel the secrets of consciousness, but it has a huge implication for the neuroscience, physiologicals, and even the AI. But in fact, in the world of scientific explosion, the science has identified 125 frontier issues. Among them, the biological physics of consciousness is one of the top 25 most important challenge problems. So it is exciting stuff. But however, the disorders of consciousness are quite different from the exciting scientific stuff. We were just talking about they referred to a state of where someone remained in a coma for over 28 days after a serious brain injuries. In this condition, the patient shows no responsive to themselves or the world around them. They cannot get any response for anything. We even see some well-known cases like the former President Shalom and the famous racing legend. I don't know how to spell it. We call the Schumacher in Chinese, and they all enduring the exciting periods of the conscious disorders of consciousness. And in China, there are many social news reports. They highlight the economic burdens that the family and the social faced when they dealing with the long-term disorder of consciousness. The patient and their family, they all have a tough situations, and they can't be treated in that situations. So in 1972, the Professor Janet and Plum come up with the term perceptive vegetative states to describe the long-staying disorders of consciousness. Over time, we got a better understanding of the residual consciousness and the responsiveness. Then in 2002, Professor Giacchino, he produced the concept of minimally conscious states, short for MCS. And then in 2012, the Professor Bruno took it further, breaking MCS down into MCS plus and demonstrate of MCS. So the common means being completely unresponsive and unawake, not reacting to anything around you. And the VS vegetative states, it refers to prepare of a wakefulness without their self-awareness or recognize environment, often with the eye-opening moment. But MCS patients show the varying degrees of arousing and awareness, now divided into plus and demonstrate MCS based on their behavioral response. It is very important for us to recognize the different diagnoses from the disorder of consciousness, so we can have a different diagnosis and a different treatment for the patients. And as we keep learning more about the consciousness, we select these complex ideas into two parts: being awake and being aware. And it means awakeness and awareness. One, by closely studying how patients respond, we add a third dimensions, the patient's motor functions. And these three aspects help doctors diagnose better and predict the comes out of these patients. And then we provided more effective treatment for the patients of disorder of consciousness. So as we dig deeper in the neurobiology, we were made some exciting discovery about how the consciousness works in the brain. It has been a journey from the old siding reticular activating systems. We all learn it from the book. This theory back in 1962, and then to the recent, the central lobe hypothesis by the Professor achieved in the 2010. In the future advancement in treatment, the method by Professor Sibet in 2019, all of these have given us much clearer pictures to how to deal with the patients of disorders of consciousness. So in the right pictures, we can see how the technical, like deep brain stimulation, focus the ultrasound, and some certain medicines drugs directly affect the central lobes. They not only amp up the brain activities, but also they turns the points to the lobe, helping the boost wakefulness and awareness. So all the treatment are useful for the patients, and the doctors can choose many different ways to treat the patients. So this progress has really opened up exciting possibilities for more effective treatment for the disorders of consciousness. And here we have this review published in the Lancet Neurologies in 2019, which talks about various methods and approaches for the treating the disorder of consciousness that shows some promising result. When it comes to the neurostimulations or neuromodulations, the main ones include DBS, deep brain stimulations, SCS, spinal cord stimulations, and VNS, which have been effective in neuromodulation the brain's activities. And it also have some treatment like TMS and TDCS. They play a role in the neuromodulations. So we previously discussed the mechanism of the clinical research of SCS in one of our previous discussions, and today we will focus on the related clinical research of the DBS for disorders of consciousness. So back in 1968, the German scientists began using the electro stimulation to target the thalamus, which shows promising result in waking up common patients. By 1989, the real DBS, deep brain stimulation, started being used to treat the common, mainly in Japan, with some reports success cases, but it doesn't until 2007 when the Professor Chief, he published a groundbreaking case reported in Nature. He talked about how DBS were used to treat a young man in a minimal conscious state for about 6 years. And guess what? It leads to a significant improvement in his behavior. So that was the turning point that opened up a whole new chapters in using DBS for the disorders of consciousness, and many doctors can start use this weapon to treat the patients. And starting from 2010, the doctors and the researchers took a more objective approach to assess the how DBS affect the consciousness. They use the technology like PET scan and EEG and the sleep EEG to measure its impact. At the same time, they gained a deeper understanding of how to select the right patient, choose the best target site of the surgery, and monitor the treatment result. All these advancements have really improved our understandings to use DBS for the patient of disorder of consciousness. So we careful analysis the some research and papers that looking for the articles from 1968 to the 2023 to today. We focus on the patient selection, the target site selections, and the modulation parameters in the clinical studies. We want to know how the DBS affect the disorder of consciousness and how it can work. And this approach will give us valuable insight in the selecting of the right patients for the DBS, and its effectiveness is training how to training the disorder of consciousness. We want to answer the first questions, that is, what kind of patients to choose. That is important for the surgeons to do the operations for the patient of disorder of consciousness. So in all of these articles we reviewed, there is a total about 91 patients with disorder of consciousness and underwent the DBS surgery. Out of this, about 25 cases didn't mention about the specific cause of the disorders. So we not get them in. And among the known cases, there are about 34 were due to trauma, and 17 result from stroke, and 15 was caused by anorexia. That is the cause of the disorders of the patients. And their age range from about 15 to 75 years. And there are also no difference in the gender distribution. The research used a different scale to assess their conditions, such as CRS scales and other score methods like GCS or the prolonged common scales, standard Pepperate disability rating, short for RDR scale, and the common and near common scale. So this data will help us to understand the patients and the various guiding systems used by evaluate the effect of DBS treatment. That is the clinical findings tell us which patients we will choose for the surgeries. And in 2018, the Chinese expert consensus on the neurosurgical treatment of disorder of consciousness. They also discussed the patient selection methods. They primarily focus on the patients who have been in a coma for more than about 3 months and shows no significant improvement in consciousness within about 4 weeks. For clinical diagnosis, the difference between the VS and the MCS, when MCS is suspected, and the additional assessment like the function MRI and the EEG or the MMN and the TMS EEG should be performed to process the DBS treatment, they required at least 2 more clear pieces of the evidence supporting to the diagnosis. So they have some conscious left in their brain. The DBS operation will work to them. This approach aimed to issue the proper appropriate patients select and improve the effectiveness of the neurosurgery treatment of the disorder of consciousness. And that is the first question. The second question is what kind of package we should choose. And this question is an important part for the neurosurgery to do their operations. So in the selected studies, the package brain areas of DBS is varied. The most common area was the CMPF. About 127 patients is about 87% receiving this target in the DBS operations, and additionally about 16 patients is 8% underwent the DBS in the area like the central salamander, short for CT. And there are 6 patients, about 4.1% target the globus pallidus. And among those with CMPF stimulations, there is also 78 patients had 2 sides implanted, and 24 has only 1 side implant, and with 20 on the left side, and there are about 4 on the right side. For central salamander and globus pallidus stimulations, the 2 side implanted are preferred. And based on these studies, the DBS targeting the CMPF, central salamander, or other target have the average effective rate of about 37% for CMPF and 28% for central salamander, and 33% for the other target of the DBS. So we can see maybe the CMPF is an effective target for these operations. Among this result, we also have many central and research institutes to have a discussion about which target we should choose, and we include the method proposal by the Professor Fan Linzhong from the Institute of the Automation, Chinese Academy of Science, to achieve the personality surgical target segmentation and selects through the structure and fiber boundary structures. So we can choose the target for the patients with his own structures, and choose different target for different patient. And we also use the intraoperative electrophysiological monitors technology to attack the change in the electrical signals with the salamanders. This helps us to point the special electrical signals correctly during and after the surgery. That is lead us to a better understanding of the mechanism of the consciousness. And the third question is about choosing the appropriate stimulations frequency for the DBS. The frequency for the neuromodulation is maybe the key to the effect result. And the DBS stimulation frequency have been extensive studies with a wide range of frequency reported in various studies. It ranging from about 8 hertz to 250 hertz. However, in the correct clinical studies, the most commonly used to optimum stimulate frequency is about 12.5 hertz. There are about 209 there are about 29.9% studies use 25 hertz, and there are about 25% studies use 50 hertz, and about 15.5% studies use 100 hertz to stimulate the patients after the surgeries. On the average, this frequency has shows an effective rate of about which is the high. When we use the 50 hertz, the effect rate of the DBS result is about 55.7%. So it has a best result. And then it's the 25 hertz. It has the effective rate about 36%. And at the last is 100 hertz. It's get the effect rates about 32.7%. So the low, medium, and the high rates may be worked different way to the disorders of consciousness patients. And for example, when we especially focus on the studied, they use the CMPF since 2005, involving about 91 patients from 7 studies. It's reported the effectiveness was 36% for the 25 hertz stimulation, and it's about 30% for 100 stimulations. And these findings suggest that both the 25 hertz, the low hertz, and the 100 hertz, the high frequency, they all promising the effect to improving the consciousness in patients. So we still don't know which frequency is useful for the disorder of consciousness, or which frequency worked to the different part of the consciousness. So they will also have more research to have this to clear. And in this neuro report, it is animal models. In animal models, the researcher explored the clinical use of DBS electrode in both human and the monkeys, as well as two-side stimulations in the rodents. These studies shows that the arousal modulations was achieved at the stimulation frequency rising from 100 to 200 hertz. And in these studies, they found that the arousal inductions was mostly effective at about 50 hertz during the CL cortical cellular stimulations, and as opposed to 10 and 200 hertz. They found that 50 hertz is the most useful frequency, and the stimulate the awake firing rate of the neurons while administer from the anesthesia may partly explain why the stimulation shows increased efficient in the data. So this finding suggests that optimizing clinical DBS to match the required neural dynamic of the effect the thalamus cortical circles could be help to improve the disorders of consciousness. And this is the studies in the monkey model. And in our teeth research, we found that the 100 Hz, this brain base markers had a positive impact on the word functional connectivities. It improved the connectivities of the whole brain areas, the regional areas, and the local areas. Well, the shim pacemakers shows no significant effect to the brain connectivities. So furthermore, we observe the improvements in the whole brain network parameters, including the clustering coefficient, the path length, and the small word furthers. And moreover, in 3 MCS patients, we received 100 Hz DBS for about 6 months. And we noticed that the remarkable increase in CRS score and the function connectivities. So these studies showed us that the DBS improved the EEG functional connectivities at the brain network. That suggests a long-term use of the DBS can elevate the level of consciousness in patients with MCS. But this study have a small data. There are only about 10 patients in these studies. So maybe we should have more research on this. And then we go to the fourth questions. It's about choosing the right stimulation intensity. In most studies, the constant voltage stimulation is used for deep brain neuroclinic typically raising about 0 to 30. And only the is depend on the patients they can who they can get field about this voltage. The major is around about 4. However, in the study conducted by Hayes, they opted for the constant stimulations in the nuclear areas with the intensity of about 2.5 to 3, and it's different from the other studies. And then the fifth question is what rhythm to choose. In many studies, the specific stimulator bandwise was not mentioned. However, in those that did, the bandwise was typically set between 60 to 3,000 millimeters. This timing of stimulation, most studies take the rhythms into count and choose the special times of the days for stimulations, often using the mini cycles. It's about 50 minutes minutes on and 50 minutes off. And then they have a day and a night big cycles during the stimulations. That is the doctors always do. And the design of the studies by Professor Chief, his studies is citing about a stimulation of about half hours on and 1.5 hours off. That is mini cycles, but for a longer times. And they also add a self-control group to account for the effect of the DBS. And how we can evaluate the effect of the DBS, we have several methods to consider. Right after the operation, we focus on the patient's immediately response to the stimulations, which often lead to important awakeness, motor control, and the behavioral improvement. And for a long evaluations, we also focus on the change in the clinical scales, such as CRS scales and the DRD scales, or the common near common scales, as well as neuroimaging and neuroelectrophysiology assessment. Different studies use different criteria to define the effect response for the stimulations. And apart from the clinical measures, we also use some various in your neuroimaging technology, like the function MRIs and the function nurse and the PET CTs to assess the change of the brain activities, the brain connectivities after the DBS treatment. And also EEG can help us to monitor the change in the sleep patterns and the function brain connectivities between the different brain areas. So we can see the effect of the DBS change the brain. Additionally, the analysis follow-up days, they can tell us the change for a long time during the DBS treatment, and giving us a better understanding of the long-term effect and potential benefit of DBS for the patient of disorder of consciousness. And the last and the most important questions is how effective the DBS as a treatment for the DOC. And we can see that all around our studies of the DBS as a treatment for DOC is found to be 43.3% overall, based on the improvement of clinical behavioral scale. And among all the studies, there is the highest effectiveness, about 50%. And while the TRUDIS studies have the lowest effectiveness, is about 28.6%. They all including excluding the case studies and some retrospective analysis. And in our long-term follow-up studies, we observed the following result in the DBS group, which consistent of about 37 cases. There are about 5 cases shows very good improvement. It's about 30.5% in half a years, and about 12 cases in 1 year, they improved from VS to MCS is about 32.4%. And there are 40 out of 37 is about 37.8% reach the endpoint event. They have a good result. And in control group, the traditional treat group, there is consists about 328 cases. We can see there have not much more patients who do the DBS operation, because the patient selection is do all around the patients, and it's depend on the families. They do the they choose the patients who will do the operations or not. In the traditional group, there are about 10 cases, about 3% with improved in half a year, and 3 cases, 40 cases in 1 year, and only 30.4% reached a good end report event. So we can see the DBS not only get the better result of the disorder of the consciousness, is also make the patients get early to improve their consciousness. So there is not a very good result, but we can see the DBS, it can do some work to the disorder of consciousness. And we also have some other studies about the response of the DBS stimulations. So this is only some studies not have a result. This is maybe we will give some discussions or the results for the future discussions. It's all about the EEG response and the LFP response for the DBS of the disorder of consciousness patients. And we can see the different response for the patients after the operations. And there is some patients' radios. This is a female patients who have the operations of DBS for both sides, and they can have the response or do the some motor behaviors after about 3 months. After about 3 months of the DBS stimulations. And that is my discussion about the DBS effect for the patient for disorder of consciousness. And it's also on the road, because not have a very extra results for these studies. So if we hope there are more doctors and researchers have the interest about these fields. So that's all. Thank you very much.
Oh, thank you, Dr. Yang. You give us a very interesting presentation focused on the DBS treatment for the unconsciousness patients. Actually, as we know, the unconsciousness caused by different kind of brain trauma or hemorrhage, other brain damage. So traditionally, it was thought as invisible, cannot be treated. But now with the DBS or some other neuromodulation treatment, some patient can recover their development. So yeah, are there any questions or comments from the audience?
Ibrahim, you have a few questions?
Yeah, it was a great lecture. Thank you, Dr. Yin Yang. This was a great lecture. It's so knowledgeable. And I will have maybe 2 questions for Dr. Yang. There are any limitation of challenge associated with the implantation of neuromodulation therapy for disorder of consciousness in clinical practice?
Yes. The first, for the DBS operations, we must have a very good structures brains so we can get the right target for the operation. If the brain have a lot of part injured, we can't use DBS because we cannot get the right target exactly. So when we choose the patients, we first we maybe have the good structures of the brains. That is the first limitations, and others is because I don't know how it exactly worked for the patients. So maybe we should have some technology as evaluations for the patients between the operation. So the third is the family opinion. If I know there are a lot of patients, people they don't think the DBS is available operations for the patient of disorder of consciousness. So we should choose the patients and then explain all the whole things to the families, and the family have a decision. That I think the 3 is all the limitations for this studies and for the operations. Yes.
Okay, thank you. That's a great answer. And also the other question is, can the neuromodulation can be combined with other treatment modality to enhance the effectiveness of the neuromodulation? Like which kind of modality?
You said the DBS or
Yes.
all the modulations?
Usually for the neuromodulation. If they can be combined with other modality to enhance the effectiveness of the neuromodulation.
Yes, right. It's a good question. That is a good question, and it's a good directions to the modulations, to the treatment for the disorder of consciousness, because different modulation technology, they worked in the different mechanisms for the consciousness. So maybe DBS can have the modulations for the awareness, for the response of the themselves, the body and the environment, and the SCS spinal cord stimulation, we get the excited activities of the whole brain connected, and maybe the blood flows, and they can improve that. And the TMS, they can exciting the local brain regions for some functions. So we can combine all the different modulations together to for the different patient. They can improve maybe different part of the brain functions. Yeah. But
Okay.
this is not have a much more research on the combined. Yeah.
Yep.
Mhm.
Okay. All right. That's all my question. Thank you, Dr. Yin Yang, for this
Thank you.
for presentation.
Thank you very much.
You're welcome. I don't know, Professor Yan Li Chao.
Yeah, I'm here. Yeah, actually, yeah. Are there any more questions on this topic?
Hello.
Yeah.
Hello.
I
Yeah,
think there's
welcome.
Good morning,
Yeah.
Ashad.
Yeah. Good evening. Good morning. Nice lecture, Dr. Saab. Doctor, I wanted to know all the cases who are having the disturbances in consciousness level can be subjected to this kind of a neuromodulation. That is the one thing. Or you have a specific cases which are means cause related. Second, which areas you feel should be stimulated, like the subthalamic nucleus, STN, or only the globus pallidus area, and how it works. Now, there is another entity we call persistent vegetative state.
Thank you.
Did you hear the
Sorry.
question? Okay. Did you hear
Yeah.
the question? Okay.
I didn't hear the second question, the end of the second questions. And
Hello.
yes,
Can you show the question, Harshad? Show
yes,
Yeah. You see, there are cases of persistent vegetative state, PVS we call, where there is a diffuse axonal injury because of various reasons. Do you still advocate in this kind of cases where you put in DBS implant and stimulate and they may improve? Or you feel there are specific questions only?
I can't quite get the point, and I think the DBS is one of the most important modulation technology for DOC during all of the technology, because it is put in the central thalamus. That is a very important part, and they have a lot of connections with all the context of the brain. So I don't understand what the consciousness happened in the human, in the peoples, and we don't know. We know quite little about the consciousness, but central thalamus, all the whole thalamus, they have quite functions, and they maybe connect with the motor, the language, and the motion, and other high function of the human conscious. So we don't know which will work, but we know in the important part, maybe neuromodulation can improve a different part functions of the brains. So DBS, I think, is maybe useful technology for the disorder of consciousness. And in our studies, all the patients has been selected by the CRS score and the function fMRI or other EEG and a lot of evaluation ways. So I don't know if it's useful for all the patients, but it worked for the patients we select in the in group until now. So maybe we should more research, more studies, and more central. They can do the work together. Yeah.
Thank you. Thank you very much. Nice presentation.
Thank you.
Okay,
Okay,
Wally,
thank you. Yeah, I'm here. So thank you, Dr. Yang. I think this is very interesting topic. Maybe we there's still some other question, but maybe we can talk later. Like someone asked about the non-invasive stimulation on some. We know so there's some other technique for those vegetative status patient. But yeah. Again, so thank you, Dr. Yang, for your nice presentation. Oh, there is another question about the cost. I think cost is quite different in different country. Like in China, the DBS cost about 30,000 US dollar for each side. So it's kind of 30,000, 40,000 for the patient. Yeah, it's mostly it cannot be covered by insurance, but yeah, it's still a problem. Anyway, yeah. So let's the mechanism. Oh, actually, it's kind of
too complex.
Yeah, we just try. It's like a black box theory. We just do it and it works. So yeah, sometimes just to start. It's the way for clinical practice. Okay.
Wally,
Okay, let's move to the second speaker, Dr.
Okay.
Iype Cherian. Okay, thank you
Thank
again,
you.
Dr. Yang.
Thank
Have
you.
a nice stay in UK.
Thank you.
Okay. Okay, bye, Dr. Yang. Let's move to the second speaker, Dr. Iype Cherian. I think Dr. Cherian now he moved to India from Nepal, right? He's the director of Institute of Neuroscience at Krishna Institute of Neuroscience, Karad, India. Now he will talk about the end of the microscope era, combined digital imaging with exoscope, microscope, and hypervision. Iype, please.
Okay. Yuanli, it's so good to see you. First of all, long time, my friend.
Yeah.
Maybe 10 years. I don't know. I haven't seen you in so many years. So yes, I have moved back to my native country, India, and I am right now in Maharashtra. It's central India, western central India, actually. So we are settling down here. We have I had been to China. There was this exoscope meeting, and in Beijing they had an exoscope. So I had gone there to the Beijing hospital, and then I had seen this exoscope in work there. We have the exoscope for about a year, and now we are slowly improving, putting in research for things what I just mentioned. So there's a lot of things I cannot talk freely because of the NDAs that I have signed, but I'll be happy to show you some videos as to how we started and what's the state at which we are. So I'll share my screen. So in 2016, we started off with collaborative work with Alicante University. And at that point of time, what I wanted was that I wanted a robot to hold a simple digital camera.
excuse me, we're not saying you're sharing. You're not sharing anything.
Are you seeing the sharing?
No, it's not sharing. You haven't opened the file yet. There you go. Okay.
Sharing now?
Yeah, playing a video, correct?
Okay, yeah.
Yeah.
So what I was saying is we started collaborating with Alicante University And then what we wanted was that instead of the microscope, which we are going to move, we want something that will move for us and that'll focus for us. That'll move along with our heads. So, and that'll focus onto a particular point. So this was my idea. I had discussed it with Professor Yasagil, and he said, this is probably the next way to go. So you can see, we put two universal robots, one fixed to a simple endoscope, one fixed to a webcam. And what we did was we programmed it in such a way that a simple pattern was recognized inside the skull, and that pattern was made to the center of this scope. This is something very easy. This is not very difficult programming. So they will scan and they will find a particular pattern, and that pattern would be the center of the scope. This means the surgeon, the scope will be using AI to focus and move and see better. So now the scope is going to look for it. Once it looks for it, it'll find the pattern. And once it finds the pattern, then it'll make the center of the scope and focus it. So it found, now it will be the center. Now, this was designed, and then the second thing that was designed was head movements, how to control the robotic arms with head movements. So we used simple Medtronic's navigation system. Literally, the guys probably hacked it, and then they got it done with that. So this was our work in 2016, and you know, I can say that even today, the best of the exoscopes don't have. Okay, so that's how we started, and then now where we are at is we have a few things in the theater right now. First of all, the few things that we have is we have an intraoperative CT. This has been my team, and so we will start off with a case that is a STMC bypass. So you can see the zoom at which we are doing right now. You can see the vasa vasorum of this ST. That is how much high zoom that you will get. And we literally had to design our own instruments for this kind of magnification. So Esculap did not have the instruments needed for this kind of magnification. So we designed our own instruments. So you can see the anastomosis now. And this high zoom is possible with this exoscope. The high zoom and the stereo depth is eminently possible with this zoom, with this exoscope. And the good thing is that everybody, my assistant, my nurse, everybody with the glass sees the same thing. I mean, there's no difference. And once you see the zoom now, and you see the stereo depth, I wish you were able to see it in 3D. Today morning, I had another session with in Indonesia with a 3D session, the World YNS Congress. We were presenting this, the same thing in 3D. So the stereo depth is generally amazing. Along with the zoom, the stereo depth is beautiful. So we complete this ICG. Now, the aneurysm clippings and all we will show you at a later phase. Let us rush through it. Now you see the zoom of this. So now that is a paraclinoidal parophthalmic aneurysm. So it's you see how easily this is a ruptured aneurysm, and how easily is this aneurysm clipping possible with this kind of a zoom. ICG, temporary clip off ICG, and another aneurysm, which is a ACOM, capsule-like aneurysm. So you can see the A1, contralateral A1, ipsilateral A1, contralateral A2, ipsilateral A2, and then the aneurysm. The clip is going in. ICG. Well, we will. Now I just wanted to show you, this is endoscope and an exoscope used in tandem. So we have an endoscopic robotic endoscope holder, which I will show you. This is the endoscope. This is the exoscope. You can see. So all the positioning, everything can be done with the footrest. There is no need for you to literally touch the exoscope after you position. You can do all the XYZ movements, everything. So this is the robotic endoscope holder. It's covered right now. So it's holding the endoscope. And again, this can be controlled in whichever way this we designed. And we're doing a transclival approach to the brainstem. So my ENT colleague is drilling the clivus. And see, this is the endoscope holder, robotic endoscope holder. And this is the exoscope. On my right side is the exoscope, and my left side is the robotic endoscope holder. So we are operating with both together. And endoscope, most often when I don't really have to go inside, it's a 3D endoscope. It's called line stand vision from Escolab. So another thing we are doing is, along with China, what we are doing is we are developing our own exoscopes and endoscopes. I saw this company, Synovation, and they are developing a beautiful exoscope, ES1. And same way, the Indian company Sanma is developing a beautiful, very good exoscope and an endoscope holder. We are designing it, and it's coming out really. The prototypes have come out very beautiful. So the problem is the companies in, you can see now how the robotic exoscope holder is holding the endoscope. I mean, robotic endoscope holder is holding the endoscope up. And it can be moved any way you want. That's the beauty of it. So you can get every perspective that you want. Now, we're going to see a few cases. The first case I would like you to see is a complex ACOM. Now, what is the use of what is the advantages of an exoscope? First of all, the ergonomics. Tomorrow I'm doing a pineal tumor, and it's just a class apart for pineal tumor. So let's see this complex ACOM for some time. And this is a fenestrated A1, and you see the magnification. This kind of magnification, I can tell you for sure that it's not available with any microscope. The maximum microscope magnification for Zeiss and Leica is about 25. Mitaka is about 70. Mitaka may be able to do this, but no other standard microscopes would be able to come anywhere near. So we are dissecting. This is like when your TV shifted from, let us say, from 720p to HD or 4K. Do you remember the time when the TV did that? That's exactly what we are seeing right now. So much clarity and so much details for dissection. So this is a ruptured aneurysm. And you can see the vessels of the optic nerve so clearly, the arachnoid, all the arachnoid bands so clearly. Again, some more Sylvian dissection. We would not have needed it, but this is fenestrated. So the fenestration was quite posterior. One of the fenestration was quite posterior. So we wanted to go a little bit more posterior. So Sylvian is being dissected. Now that's a fenestrated segment. This is the interhemispheric fissure. That's aneurysm neck. You will see it very clearly now. So other than the magnification, clarity, stereo depth, ergonomics, and it is a harbinger for future. So for example, I was telling John today that the exoscope, you can superimpose the angiogram in a VR model, not the 2D overlay, in a VR model onto this exoscope picture. And when you do that, you will have, you will clearly know where exactly is, this aneurysm, where exactly are the vessels, where exactly are the perforators, and so on and so forth. And then later on, the surgeon doesn't really know which vessel he's dealing with. You can introduce AI and the exoscope will tell you this is A1. If you don't know, this is A1, this is A2, and this is the aneurysm. So go clip it. So, if you introduce AI, the possibilities are endless. You see ChatGPT doing what it does, and imagine introducing AI into the operation theater, and it will tell you this pattern, this from the scan, this looks like A1, this looks like A2, and this is the aneurysm. This is exactly where you should put the clip, and the clip size you need is this. Okay, imagine the exoscope telling you that. Okay, this is the future. So this is what I call hypervision. So we wrote a chapter in the digital anatomy for the textbook, UNESCO textbook, and we wrote about hypervision, and it's precisely what we wrote about. Let's see. Now, a lot of people ask me, what happens when there's a tumor? What happens when there's a rupture? What happens then when it's slightly difficult? So we'll go with all that. We're going to see a difficult case here. It's a pica aneurysm. It's not really difficult, but the difficulty was by the fact that there was when you were dissecting, the first thing that came to your field was not the aneurysm, but the blister. So you are going to see, this is the distal pica. This is a distal pica. You must remember it's a distal pica. It's a proximal pica is out here. So I'm going till a velar. So this is the distal pica. And this is a blister. This is not the aneurysm, it's a blister. You will see very soon. No proximal control now. So I'm keeping on dissecting it. Absolutely no proximal control. If it ruptures, well, it's a bit of a trouble. So I'm dissecting the arachnoid. You see the arachnoid bands under very, very high zoom. So this blister is only 1 layer thick, while the aneurysm is 3 layers thick. The blister is only 1 layer. So I cannot even stretch these arachnoid bands. Forget dissecting them blunt. So it's complete sharp dissection. And this arachnoid bands has to be taken. Now, to my shock, I found that the cerebellum is also attached. So I'm going to take a long time dissecting this aneurysm. I don't want to sit down here with that kind of long time, so you can see how I dissect it out. Keep on dissecting it out very gently. This is whether you have an exoscope, whether you have whatever scope, patience is patience. There is no substitute for it. So now you're dissected out the aneurysm. That's a blister. Okay. Now I've got the proximal pica. Till now I was seeing only this part. Now after I dissected the cerebellum off completely of the aneurysm, now you can see the proximal pica, this aneurysm, and the blister arising from the aneurysm and the distal pica. And again, I'm going to put the clip on, but I'm not happy because I have to see this corner. If I don't see this corner, I may not, because there are some arachnoid brands here which will not allow me to put the clip properly on. So I'm seeing whether I can put the clip, but you see these bands, so they are not. So I try and put the clip, but I'm not happy. These clips, these bands are there, and I cannot see the corner. So I take it out and I dissect further, and I do something crazy with the. I'm trying to, decrease the size of this blister. These are insulated bipolar tips, very specific. So now you see there this black coloration starts appearing. So I have to be very, very careful, but I have proximal control now. So if it ruptures, I just put a proximal clip. So it's not much of a problem. So I'm able to shrink this. Give me a second. Hello. Yeah, Mangesh, you reached. Yeah, so I'm going to clip it now. Yeah, now I've taken off the arachnoid off, and I'm going to clip it right now. You can see the corner, and the clip will sit perfectly now. Yes. Yes, so it's reconstructed beautifully now, the pica. And you can see that turn, and then that's a turn, and then it goes off. So you can see the ICG. The only thing I need to look at is the ICG for the distal pica. And you can see it's beautifully filling the distal pica. That's a distal pica filling. So let's say an MCA rupture. Okay. Now, this is a rupture made even more difficult because I told my consultants that we're not going to put a temporary clip, whatever happens. Okay. So no temporary clip, because this patient had multiple plaques. So you see the size of this optic nerve, size of the zoom. So we told my consultants, there's no way you can put in a temporary clip, because temporary clip means this patient can have a chance of a stroke. So we are not going to put temporary clips. So that means if you have a rupture without temporary clips, it's going to be a little bit of a messy business. Especially an MCA is something that you can put a temporary clip and you have absolute control. So here you can see the vessels. The vessel size, you see the vessels, the micrometer vessel sizes. So we are opening the opticocarotid cistern now. Let's get into the rupture. So we're dissecting everything. The consultants are dissecting everything. So now that's MCA completely dissected. Multiple vessels around it. It's a ruptured aneurysm just hours before the surgery. This is ruptured. Okay, so the clot is not very strong. The clot is still sitting there. Okay, and so we are mobilizing, and while we are mobilizing, so you can see the plaques there. So the yellow plaques around. This means there is plaques here also. This means if you put a clip, you are going to send probably a plaque into the circulation, and then you blame vasospasm. That's why the patient had some problem. So here we decided that no temporary clipping. So we go ahead, and it's already started leaking. This aneurysm has started leaking. Okay, that's aneurysm. There's one branch is somewhere here, and when it's bleeding, I come in. So now this is the time I come in, and so no temporary clips. This is it's ruptured. So I want you to see the full thing, because this is, as young neurosurgeons, these are things that you will go through. Of course, I'm not asking you not to put a temporary clip and see what happens right now. So, well, I'm down about 1,000 clips, so 1,000 aneurysm clips. So after you've done about 1,000, you can afford to do this, but not before that. So you can see the whole field is turned red. That's the beauty of aneurysm surgery. So you've got to be careful. No shouting, no tremor, and no temporary clipping. So we are slowly trying to get some control. So, but then, sometimes vascular surgery can be so crazy that there will be no control. But one reassuring thing is that, there's only around 5 liters of blood, so the bleeding has to stop sometime. So, and then well, we didn't have too much blood loss, so don't worry about it. This is at high zoom, so that is why we're seeing that blood. So now my anesthetist is getting some BP under control, so it's ruptured. So still people are asking me very gently, should you go with the temporary clip? I say no, we will just continue. And we continued, and in a few seconds, you must understand that the whole thing is not lasted more than 30 seconds. So, but it will seem like an year for a surgeon. So that is the aneurysm. Now it is bleeding into my suction. And now I take a bayonet and tell the aneurysm, naughty aneurysm, and give it a hit on the head. Okay. See, that is it. Okay. Naughty aneurysm. And then we put a clip. All right. You can see the plaques everywhere. So no hurry again, just the guy was naughty, so we put in a clip there. All under the exoscope. I mean, we didn't feel the need that we should shift to microscope at any point of time, because beautiful. So, and you can see the rupture site here. Okay, so no temporary clip at all. All right. And this patient went home without any deficits, nothing new, no new deficits. Okay, 3 days later she was discharged. So question is whether can you manage problems? Yes. Now I'm going to show you one more case, or maybe 2 more cases where we've been doing with the exoscope, and this is a cavernous sinus meningioma. So you can see the cavernous sinus meningioma, the carotid is within it. Okay. So we are going to do the standard orbitomeningeal band dissection. So it's my fellow from Argentina who's drew all this, Pablo. So now I have cut out, dissecting into the meningioma. Okay, the orbitomeningeal band is cut, and the meningioma is already seen. So I'm taking the temporal lobe away from the meningioma, peeling the whole temporal lobe away from the meningioma. And after that, you can see the cavernous sinus nerves already here. So once the tumor is taken out from the temporal lobe, you see cavernous sinus is medial to the temporal lobe. So once you mobilize the temporal lobe, peel the temporal lobe away, then you can take out this. Once you do that, then you have the V1, the fourth nerve. It's a band actually, it's a smaller band. It's V1, V2, and the cavernous sinus is there. So a lot of people tell me, oh, cavernous sinus, you should not go in. Nothing like that. If you're doing it at high magnification, you can. That's a third nerve. That's a clinoid. So now, because the tumor was into the superior orbital fissure and also into the orbit, we have to decompress the orbit and the superior orbital fissure. So I have to take out the clinoid off. I'm taking the clinoid off. 0.75 millimeter drill. That's a third nerve. That's a third nerve. And the fourth nerve is here, overtaking the third nerve at the superior orbital fissure. So you see the zoom at which we are operating. Okay. Very unlikely that you will see it anywhere else. So the optic nerve deroofing is being done. Tumor is already popping out here. We take all that, decompress all that. Now you can see the cavernous sinus. That is, we are going through the Parkinson's triangle right now. That's the second nerve, third nerve, the fourth nerve. Okay, and then between the 4 and the V1, we are going into the Parkinson's triangle. No injection, no fibrin glue injection was done here. It just because the tumor is there, this will be less bleeding. If the tumor is not there, then there is bleeding. So we are just opening up, and then you can see with very little traction, we are able to. That's a 6th nerve medial to the V1, and it's just like a cadaver dissection. You know, it's beautiful because you can see all the structures so beautifully. So inside the cavernous sinus, you've got to be careful because the 6th nerve is crossed by the infralateral trunk. So you must know where the infralateral trunk is. So there's a C4, C5, C4 transition to C5. That's the meningohypophyseal trunk is there. You cannot tear it away from the carotid because there will be a lot of bleeding. And if you use your bipolar, that'll be disaster. So now the whole tumor in the cavernous sinus is taken out. She had already third nerve palsy, which improved after 2 weeks, and no deficits. Okay, so it's because the tumor was soft. If the tumor was hard and invading, then it's a bit difficult. Maybe I can show you one more video, and then we can finish the session, or maybe just 2 more videos. I would like you to see the endoscopic robotic holder also. So, sorry, this is not this one. This is the cystic solid meningioma of the petroclival region. Okay. So, let me see. Let us show you the images. That is the lesion. We thought it's a schwannoma, but the biopsy turned out to be meningioma. We were surprised, but we saw that it was going to the Meckel's cave also. We thought it was a 5th nerve schwannoma actually, but patient did not have any 5th nerve symptoms. So it's the same thing, orbitomeningeal band dissection. Then that's a third V3. That's V3, and that's a Kawase. That's GSPN. So the Kawase triangle is taken out. Once a Kawase triangle is taken out, then you are drilling. You're drilling between, this is the cochlea, this is the 7th IAM, so you will be operating between the 7th and the 5th. So it's a very, very tailored drilling that you need. So after you take it out with the bone QSAR, then bipolaring the superior petrosal sinus. There's a superior petrosal sinus. Just before you cut the superior petrosal sinus, you will have to bipolar it. So the temporal fossa dura is opened. Then now you're cutting the superior petrosal sinus. So making it the cut continues with the posterior fossa. Now this tent is going to be cut completely. Now the Meckel's cave is opened and you find tumor there. It's under very, very high zone. The Meckel's cave is opened. Now that's a tumor. And this is the margin of the tent. You must see that this side is the margin of the tent. So you are going to communicate. So you will see now what I'm bipolaring the last bit of the tent. You can see that's the tent margin. That's a tent margin. So your fourth nerve will be here. That's a fourth nerve. That's a fourth nerve. Okay, that's a fourth nerve. And so once I do that, I'll be able to cut. Once I cut the tent, I'll be able to get into the petroclival. This tumor, that is the seventh nerve, IAM, going into the IAM. Fifth nerve will be found here. So I'm operating between the fifth and the seventh. Opening the cyst. After I open the cyst, then that's a seventh nerve. You can see the seventh nerve there, and that's a fifth nerve there, retrogastrian fifth. So I go into the cavity now, and the problem is this is attached very much to the brainstem pia as well as to the basilar. So just shaving it off. Under endoscopic guidance, shaving every single bit of tumor off. So no more pulling, pushing or anything, okay? Just shaving it off. Now with the endoscope, you identify the basilar, and the exoscope, you cannot see the basilar. So with the robotic endoscope holder, we see the basilar here. That's a basilar. So we will understand where is the basilar and then go for it. That's a basilar. With the exoscope, you can see the basilar there. So go on and keeping on shaving out every single bit of the tumor. Okay. Right. So at last, we will show you something that we did with the robotic endoscopic holder. So you can see this is a lesion. This is the lesion. So there was no way. Somebody tried it retrosigmoid and they could not even get a biopsy. So it was difficult case. So we decided to go through the nose. So that you can see there. We thought it was a chordoma, but it came out to be a pilocytic gastro. And it was 13.5 centimeter from the nose. Quite deep, very, very narrow corridor. So we went transclival. I'll just rush through the video. So the exposure, LOCRs, the lateral opticocarotid recess. That's the clivus, the sella. That's a carotid there. Drilling out everything now. I don't think very many cases has been done in the world with this kind of a tumor. I'll tell you why exactly. Why exactly is that? We will tell you why. So now I'm drilling everything. That's a Gulfar region of the cavernous sinus, where the superior petrosal sinus, inferior petrosal sinus, and the posterior segment of the cavernous sinus join. So we have to open that. It's not an easy bleeding, yeah? The Gulfar segment bleeding, because the sixth nerve has to be lateralized. Now I'm going in. Once I open the dura, I'm going into this space, and the problem is the vertebral arteries are there. That's a vertebral artery. So like this is the two vertebral arteries. This is a basilar artery. This is the sixth nerve there. Okay, it's exactly like that, what you're going to see. So that's the two vertebral arteries. And with the curved bipolar, you're holding up this clivus dura and bipolaring it off. The problem is all your vessels are in front. Unlike when you're doing in nasal, if all your chordomas and all your vessels are in back. So this one, everything. This is sixth nerve. You can see the sixth nerve there. sixth nerve, it's going into the Meckel's cave. So that's the inferior petrosal sinus. So vertebral artery, two vertebral artery, the basilar is here, and I have to go between this window. And I have to take the tumor out from there. So that's a basilar and that's a perforator. That's a basilar perforator. So you're going through the nose between basilar perforator, sixth nerve, basilar, vertebral, and taking out the tumor. Okay. And at 13.5 centimeter. So you have to be very, very careful, very, very careful. So we went ahead. We could not do any hemostasis, but we could get good, excellent resection. So you can see now, only blood in this region, only blood. So you can see that this entire thing is just filled with blood. And she has, except for a mild sixth nerve palsy on one side, she didn't have any problem. So stopping to share. So the future, I believe, this was done with an endoscopy, robotic endoscopic holder. So as I showed you in the first, my ENT colleague was drilling the clivus when we were doing this. So the point is, the future is not microscopes. Okay, the future is exoscope, digital imaging, artificial intelligence, robotic endoscope holders. Maybe both will combine to become one instrument with mixed reality, artificial intelligence, all that. So it is coming very soon. So we are working on it. And I think after cystonostomy, my next mission would be to get this modern imaging, what I call is hypervision, into neurosurgery. Thank you very much.
One link.
Thank you. Yeah, thank you, Iype. Thank you for your nice talk. Actually, yeah, I think you show us your excellent surgical skill. Also, the fantastic new instrument, new equipment, the exoscope. I think it as you told us, it can provide a wider vision window and also more clear visual field. So yeah, are there any questions from audience? There is question. How many people
Yes,
are
yeah, Yi Yang is asking me that.
How many people are needed to operate? I mean, I guess it's how many assistants?
We need one assistant, one assistant. Hello? Hello? Can you hear me?
One assistant. Yeah.
Yeah, so we need one assistant because generally my hands are free all the time. It's not like the microscope when I have to take my hands off and move it. So my hands are always, I'm not moving the microscope, exoscope at all. The exoscope is dancing in front of me with my foot switch. So I don't need anybody to, you know, to kind of assist me, but one assistant for retractors, for suctions and everything is good. So generally one of my consultants or my wife helps me with this. Any other questions that anybody would like to ask?
Okay, continue.
Hi.
Hi, hey, Harshit. Good to see you.
Good to see you. Well, I'm observing this times you are doing these things. I've seen all these cases being done, especially this. I'm fascinated by this transclival. The use of robotic arm for the endoscope holding, wonderful technique. And yes, it is challenging to go between the sixth nerve and basilar perforator. You're scared to, you know, don't want to rupture anywhere. Wonderful. Now, do you think there will be a low-cost equipments available now soon? Because just now, so it's very expensive. This everybody cannot afford it.
Yes. So Sanma, we are working with Sanma. See, I worked with Escolab for almost 4 years and developed this first scope. But then I'm very disappointed with their pricing because it's $1 million and probably the second version will be close to $2 million. So I'm very disappointed. So now we started working with an Indian company, and which is Sanma, and they have produced a beautiful prototype. I'm very, very eager that when it comes out, so we'll have to iron out all the problems associated with it. And they've also got this endoscopic robotic holder, their own endoscopic robotic, which is brilliant. So yes, we are looking at a much low cost exoscope right now. At least 1/5 or 1/4 the cost of the Escolab exoscope or any other exoscopes in the market. And the robotic holder is going to be even much more cheaper. So, and that too, the exoscope that I mentioned was 3D 4K again, just like Escolab. And the HD one is even much more. The HD one is brilliant. I mean, I saw that it can get beautiful magnification, even better than the ones in microscope, but not up to the magnification with the 3D 4K. The HD one is even more, much less costlier. So the HD 3D one is very good. So we will have a lot of low-cost options in India. And China is also doing ES1 from, I think, Sinovation Med. So they are also doing a exoscope. So I'd be very happy to talk about it once I see it. I go to Beijing and see it, then I'll be happy to talk about it.
I'm sure they will be incorporating AI into that low cost.
Yes. So both
that
the
is
Indian
something
companies,
which is very fascinating.
both the Indian companies and the Chinese companies, both of them are incorporating 3D 4K robotics and AI into. First of all, they are incorporating mixed reality into it, and then later on AI.
Fascinating. There is a learning curve. We need to learn. Everyone has to go through it to learn, because so much of zoom, a little bit of movement here and there, it zooms out.
Yeah,
We have to get used to it.
True, absolutely.
Great. Thank you.
I have maybe one question or maybe one requirement about Professor Iype. I have been seeing this exoscope like 2 times in Huashan Hospital actually for spine surgery. I would like to ask about what is your opinion about aneurysm clipping, because sometimes we need like intraoperative ICG. I think the exoscope can still not able to have like the ICG in intraoperative right now, right?
No. What I showed you, ICG was all from the exoscope.
Oh, okay. So I thought is something else with associated with the microscope. So
No. The filters can be put into any scope. There is no problem at all. The filters can be put into digital scope. In fact, it's easier to put it into a digital scope and enhance it. So the ICG is available with all the exoscopes. Definitely, it's available with the AOS, and the Indian scope also will have the ICG.
Okay, that's quite interesting. I have been seeing many times they're using it for some spine surgery. The image is fascinating.
Yeah,
that's the most accurate image I never see in intraoperative area.
Yeah, absolutely. You are right. When you have seen it, you will believe it. It's amazing, truly amazing.
Thank you, Professor.
You're welcome. So if there are no more questions, then I'll carry on. Thank you, Yuan Li. Thank you, John. And it has been an honor presenting on this.
Thank you. Yeah, so you're always welcome to visit China again.
Thank you.
Yeah, you spend a lot of time in China. You've been there a bunch of times, right?
Yes. I have gone more than 20 times to China.
Yeah. You can do like Mr. Kissinger. He said he's 100 years old and he had visited China 100 times.
Maybe I'll visit more than 100 times, I guess.
Yeah, you should. You will.
I love the Chinese food. I really love it. Every time I go, I love Chinese food.
Thank you.
Okay, very good, Iype. We look forward to hearing more from you. And now we have, the king is broadcasting in about a half hour. He's talking about revolution spine surgery at Tool Goel, well known to everybody here. Okay, we look forward to hearing more.
See you guys. See you
Okay,
guys.
thank you,
Thank you
everyone.
very much. Thank you very much.
Thank you.